Do we ever do anything to the blend?
I've never recommended a blender on VV ECMO. Blenders really, in my mind, are like, if you think about what a blender is supposed to do, what a blender is supposed to do is prevent hyperoxia, which we don't ever really get in VV ECMO. We get that a lot in VA ECMO. And so, but in VA ECMO, you can't just come down on flow and deliver less oxygen because you're also providing cardiac output. So the way we work around that is to decrease the FiO2 of the sweep. In VV ECMO, where like your flow has no cardiac output influence at all, if you actually didn't get into hyperoxia, you just simply come down on flow. And I think like by doing that, you simplify the process of like weaning off of ECMO by not introducing something that I don't think has a ton of clinical value. You can ask a follow-up question.
I didn't get the answer quite clearly.
So when we use blenders at the University of Michigan, when we use blenders, it's because we are experiencing hyperoxia, PO2s in the patient of like 2, 3, 400. That only happens in VA ECMO. And if like we were like in an ideal world, I still wouldn't want to add a blender. I would want to come down on the flow and deliver less oxygen. But with VA ECMO, I can't because I'm delivering cardiac output and my blood pressure may drop. So the way you work around that is to decrease the FiO2 in the sweep, and that'll bring your PO2 down. In VV ECMO, say I still get that same 200 PO2, I'm uncomfortable with the PO2 of 200, I can just simply come down on flow and deliver less oxygen, and I don't need to add the blender to do so because I won't be dropping their blood pressure like when I drop the flow.
Blender is not routinely used in orbit.
We don't, not in VV ECMO, and I don't I can't say that we never do it. Sometimes I'll have a physician that will want one, and what I'll say is that whenever we do it, people get really confused by exactly what you just said. Is do I come down on the FiO2 on the ECMO circuit, and do I come down on the ventilator? And what I would say is don't put the blender on, and then it simplifies the question, and it's obviously the ventilator.
Sweet gas flow is like 100% FiO2 or?
I always use 100% FiO2 in VV ECMO. Yeah. Okay, I'm going to go ahead and get started so we can make sure everybody gets a chance to eat. I'm still Steve Robinson, and those are still my conflicts. And so what I want to go through here is a little bit more of the kind of the bedside process of this. So Ross has already kind of talked you through like the Rush study. So I'm going to look at that a little bit closer and kind of look at some of more of the bedside aspects of that. Then also we breeze through some of the RV stuff as well. Look at like fluid management on ECMO. Ross has already done the VV recirculation, just add a few of the points there as far as bedside stuff. And then we'll talk about weaning and preparing for decannulation. So as Ross mentioned, this is a study that kind of got all of our attention as ECMO coordinators throughout North America regarding how to get people to survive from respiratory failure, VV ECMO. And so this is obviously the title of the study. And then we've been through some of these results, but just to kind of hammer them home a little bit. This particular study looked at, so they kind of started this process in COVID and then continued afterwards. And so essentially what they're calling this is awake ECMO, basically having patients that are awake, ambulating, and participating in their care. And so they had 62 patients total. 34 of those were treated for COVID. 28 were treated for anything other than COVID. And they had, of the total all awake, 62 patients, 53 survivors for a survival rate of 85.5%. During this same period at the University of Michigan, where we've been doing this for 40 years, we had a survival rate of about 55 to 60%. So these are phenomenal results. Also overall had about a survival rate of about 55% during the same time period as well. So this is why this got all of our attention. And then looking at the COVID and non-COVID groups, we still have that same 85% survival rate, giving us some indication that this model has utility across all ARDS. It isn't necessarily just specific to COVID patients. So what so Ross has already gone through the right heart protection part of this, but that's not all that they did at Rush. And I'm close friends with some of the people at Rush and have had extensive conversations with them about how they treat their ARDS respiratory failure ECMO patients. And what I would, in my personal opinion, I think what they're doing is like what should be best practices for adult respiratory failure ECMO. And I call it the 3 earlies and right heart protection. So their philosophy, this is going to run counter to Dr. Raghavendran just a little bit, but we can debate a little bit. But early cannulation, early extubation, early mobility, and then obviously right heart protection. So just kind of walk through the 3 earlies one by one here. So as I think Dr. Raghavendran mentioned earlier, is that early cannulation tends to lead to more successful ECMO. And this is something that we really struggle with at our center because we're kind of a referral center. And so a lot of our patients are starting at rural areas of Michigan. They'll be in ARDS on a ventilator at high, like on non-productive lung settings for several days. We'll get them. And then it's hard to get to the early cannulation because we're kind of starting behind. But if you're at a center that you're kind of getting your patients at the door, so to speak, what I would highly recommend is try to do all of the strategies that my colleagues have given you the last 2 days. But if they're failing after 4, 5, 6 days, that's when you probably start looking at it, considering ECMO. Anytime that we've gone past 14 days, 15 days, and then cannulated people for ECMO, the results have been pretty poor. So try to stay within those Eolia criteria of getting on in 7 days. And I think you'll have a lot of success, and I think that's partly why they had a lot of success. Is this is something that they adhere to very closely at Rush. This is where it gets a little bit more controversial. So over at Rush, they did early extubation. So part of their philosophy there is we went on the ventilator. We were unable to manage the ARDS. We went on to ECMO, and now we're going to rely 100% on ECMO. And so for early extubation, what I have listed there is obviously the criteria that they went through to evaluate whether a patient was eligible to be an early extubation candidate, and I think they make a lot of sense. Neurologically, you want somebody that is awake, alert, oriented, and can follow directions, commands. You don't want anybody that is still going through delirium. That's obviously a decannulation risk that you don't want to take. You want some level of hemodynamic stability. You don't want to have to be giving these type of patients a lot of fluid resuscitation, because that'll obviously make their extubation a little bit harder. You want to be, what Raghu has said multiple times, is you want to be stable on ECMO. And what we mean by that is that we can reasonably support you, but not at maximum ECMO settings. And so you're going to need, if you want to consider extubating a patient, you're going to need to have some level of room to go up on your flow, go up on your sweep. Because ultimately the goal of early extubation is to get to what the next early, which is early ambulation. And in order to do that, you can't be at maximum ECMO settings at rest. And then obviously there's some GU, GI things. So one of the things that Rush has told me that they really like about this early extubation is being able to have patients eat, provide their own nourishment, things of that sort. And then finally, they took a more aggressive stance with hemoglobin, so they drove the hemoglobins up above 10 to get that additional carrying capacity. Because obviously, if you do extubate the patient, you are going to de-recruit the lungs, as Dr. Raghavendran said, and then you're going to have to deliver more oxygen via the ECMO circuit. And so, let me see. And if you remember, I don't think that there's any real disagreement between me and Raghu. But what Rush is advocating here is that what Raghu is saying is if you allow the lungs to de-recruit, you're going to have a really hard time re-recruiting them. And if you remember what Ross said, they had really long runs in Rush. And so what the trade-off they're making is we're going to come off of positive pressure ventilation completely, and then we're going to stay on ECMO longer. Because with this early extubation that Rush was doing, they never re-intubated. So they just stayed on ECMO until the patient could come off of ECMO to a high-flow nasal cannula or some other oxygen delivery source. Anything to add, Raghu?
This is tricky, right? The normal strategy for respiratory failure is institution of mechanical ventilation. ECMO was an adjunct to mechanical ventilation. Now we have put people on ECMO, and now you're saying I'm going to take off mechanical ventilation. So this is incredibly tricky, and I can see problems with it, right? What are the things we worry about patient suddenly will start developing this coagulopathy after 2 weeks. And that's why Ross and I are thinking, oh, okay, it's time for us to start. How are we going to get him off ECMO? Can I give him more ventilators? Here you can't do that, or you may have to, they are not intubating. So I don't see outs. If they develop a bleeding complication and problems with it, then we are in trouble a little bit.
Yeah.
This is another approach.
Yeah, and agree. And I don't think we have to be terribly dogmatic about early extubation versus, because some of the debate that we've had among ourselves as ECMO coordinators is like, what I think is most important here is to get them to a state where they do not have to be sedated and laying in bed. And so the alternative approach is you could trach and then do the lung protective vent strategies there. Ideally, what we want to do is get that ET tube out that prevent, because usually when I see patients that are being left inactive on ECMO, it's usually because they're intubated and they have a ET tube on a ventilator. So either way, get the ET tube out, and that's going to free you up to, I think, do more ambulation. So just getting back to early extubation, though, obviously, Raghu kind of touched on these just a little bit. The benefits, obviously, are accessory muscle usage of breathing. So they're going to go back to negative pressure breathing, and they're going to start using the same muscles that they always did to breathe, which kind of decreases some of the ICU-based acquired weakness. Decreased use of sedatives, and I think this is the key here, is making sure, what I always tell my staff when they're getting upset about a patient coughing a lot, being a little delirious, being anxious, is if you want to kill a patient, sedate them and leave them in bed and don't move them. I can tell you for certain, with near certainty, every clinical environment I've ever been in, inactivity kills patients. Do not let your VV ECMO patients be inactive. And then obviously if you are extubated, what I'm driving at is better facilitates pulmonary rehab. And then obviously the risks, as Dr. Raghavendran already talked about, is bleeding risk. And then obviously you lose your airway protection. You are going to allow the alveoli to de-recruit. You're going to have a longer ECMO run as a result. And then you're going to also lose your ability to suction the airway, and do any type of bronchs while on ECMO. And this, to me, I think is probably the biggest of the earlies, is early ambulation. You want, like I said, you do not want to have your patients laying in bed. And so the benefits of early ambulation, in my mind, are very numerous. Obviously, it's going to decrease the prevalence of ICU acquired weakness. You're going to probably reduce your mechanical ventilation time because your patients aren't going to be developing said weakness. You're going to be able to probably liberate from sedation faster, which is going to get you less severe delirium and shorter deliriums. And obviously there's mortality risk benefit to patients getting up and getting moving as well. And we kind of touched on this earlier as well. The goal for most of us when we're first going on to ECMO with an ARDS respiratory failure patient is to get those lungs recovered and get them to a state where they can go home with their natural lungs. That's not going to work for everybody. At some point in time with some patients, we're going to have to transition them from bridge to recovery to bridge to transplant. And what we would be doing is, if you're doing all of these things, you're already doing the prehab for the lung transplant, and they're going to be in a great position to be eligible for said lung transplant. All right, so just kind of piggybacking off of the early ambulation, there is some additional clinical evidence for this. So this was a single center retrospective study looking at 30-day survival of ECMO patients based on the type of mobility that they had while they were on ECMO. And then obviously on the bottom is the length of the ECMO run. And then obviously we have in green, they are able to stand and ambulate. Blue is they are able to get up to a chair independently, or with their own strength at least. Red is doing physical therapy in bed, and then black is obviously no therapy whatsoever. And what you'll see is as the level of activity decreases, the mortality starts to increase. And obviously there's always some level of the people that can stand were probably less sick, and there is some level of that. But I think overall, this is a pretty compelling case that activity helps heal ARDS and get lungs working again. And then two of these did meet looks like getting up to a chair and staying in bed were met the level of statistical significance. And then the last is the right heart protection, and I'm only going to touch on this kind of briefly, but because we've already kind of gone through this, but this is additional evidence for why you may want to consider protecting the right ventricle on respiratory failure ECMO. So this is also a single center study from the University of Minnesota, and what they did in this particular study is they cannulated patients for ECMO, and then immediately, like within I think 6 to 12 hours after cannulating for ECMO, they did echo studies on these patients looking for signs of right heart strain and right heart failure. And what you find here is that even doing this early on in the course of going on ECMO, is there's still a survival benefit to not having right-sided strain and heart failure. So what this is demonstrating is that if you have right heart strain and failure going on to ECMO, ECMO is not going to fix that for you, and you're going to have increased mortality as a result. So the blue line there with the higher survival rates, the first kind of column there is survival to decannulation, and there's a huge drop off there. And the blue is the patients that had no signs of right heart strain or failure. The orange line with the lowest survival rate is where they saw early signs of right heart strain and failure, and then obviously the trend continues on to survival to hospital discharge. And then this is a VPA cannula. This is a cannula I used to sell. I don't want to get too deeply into it because Ross has already covered it. Couple things that I do want to add is it obviously, as we said, it protects the RV, minimizes recirculation. What I like it for as a bedside clinician is the middle one, which is this is the easiest cannula to mobilize a patient with. So obviously we've already covered why 2 sites VV with the femoral cannula is difficult to ambulate a patient with. It is also difficult to ambulate a patient with a bicaval dual lumen crescent. The reason being is we saw all those pictures that Ross was showing us as far as that jetted outflow. What I have found as a clinician, when I try to get somebody up and walking with that cannula in, it starts to torque, and that jetted outflow isn't going towards the tricuspid anymore, and now I have 100% recirculation as they're creating all this CO2 from the ambulation I'm about to do. With this cannula here, since we're draining and then reinfusing across a valve and there's minimal recirculation, this thing can spin around in 360-degree circles within the vessel, and it won't matter at all. So like you don't get into that recirculation issue when using this cannula for mobilization. The obvious disadvantages are, like Ross has already covered, is challenging in placing. We've actually had a few sentinel events with these pulmonary artery ruptures, injured right ventricles from trying to like get that curve in there. So it's very hard to place as far as technical skill wise, and then cost is extreme. 2-site VV cannulas in the United States cost about $300 each for us. A bicaval dual lumen cannula costs about $3,000. A VPA cannula, depending on who you buy it from, can cost anywhere from $8,000 to $13,000. And so what Ross's study found and what my study found is that right heart failure and strain occurs about 25% of the time. So you're spending a ton of money to to prevent something that doesn't happen in the majority of ECMO patients. But when it does happen, it has a huge impact on mortality. Within that University of Minnesota study, one of the other things that they mentioned is that they didn't find a specific one data point that kind of pointed to like any type of survival. So they recommended a mixed monitoring strategy of looking at your TAPSE, looking at your RVSP, and then looking at your septal wall function. So this is something that we talk about a lot. We meet together every week to discuss our VV ECMO patients, and I constantly remind people, let's keep looking at making sure that we're monitoring for right heart failure. Oh, let me go back. So moving on, any questions on any of the Rush stuff? Okay. Moving on, so keeping the patient on ECMO. And so what I mean by this is essentially preventing decannulation. So this, unfortunately, most everybody in the ELSO community will tell you that decannulation is a never event that should never happen. What I will tell you is it does happen. It happened to us in August of last year. We had a patient on VA ECMO have an arterial cannula migrate out. She bled out and did not survive. And so this does happen. I had to obviously do the root cause analysis of all of that and have obviously some strategy that we put in place since then to prevent this. But part of that was we surveyed other centers about how they were preventing it and what issues they had. So we had 15 centers anonymously respond to us as far as like, had they had a decannulation episode and what did they think contributed to it. 15 centers responded, 13 had decannulation episodes. 11 of those ended in mortalities. If your arterial cannula, especially, or your return cannula especially comes out, you're not likely to have a survival there because if the return cannula comes out, you're going to exsanguinate the patient in about 1 to 2 minutes. You have to have a pretty quick response time to save these patients. So this is actually the cannula of the that we lost that actually came out of a patient, and this is when we realized that we needed better strategies than what ELSO had actually puts in their guidelines. So the ELSO guideline is that the cannula needs to be attached to the patient in 2 places. And so I actually was one of the specialists taking care of this patient. This is what I found on day 1, post-cannulation. So this was a VA ECMO patient cannulated in the cath lab. And then this is what I found in the ICU the following morning. And so when I saw this, I let our team know I didn't feel like this was secured adequately. And that was relayed to the cardiac surgery team, who said they disagreed. And based on the ELSO guidelines, I didn't really have anything I could push back with, because what they were arguing is that at that cuff up there is a suture, and on the, I don't know if you can see see it very well, but there's an additional suture right here. So the argument was that there's already 2 sutures. And this is where we realized that going off of just the ELSO guideline isn't sufficient, because what ends up happening is that cuff, the suture on the cuff doesn't do anything, doesn't hold the cannula in at all. It's completely useless. Our specialists didn't know that because we don't put cannulas in. And then the second part is you don't want this suture is also misaligned as well. You don't want your only suture to be on the wire bound only, and this is also placed really poorly. It's on an expanding piece of the tapering piece of the cannula. So as this cannula, so as you can see from this picture here, this is wide here and then starts to narrow as it comes out, goes in. So as this cannula migrated out, it's now trying to hold something that was skinnier than it was holding before and provided no protection when it started to migrate out. So the 2 questions that we had to answer after having this episode and finding out that the ELSO guidelines weren't specific enough for us is, where do we put the sutures? And where we found that the best place to put the sutures is on the soft tubing. And the reason that the soft tubing is the ideal place is it allows you to create some cinching, gives you a little bit more grab, whereas the wire bounding is really hard, rigid, and you can't get a real grip. Your sutures don't get a very good grip there. So we have, our standard now is two sutures on soft tubing. So that's the standard now. Sorry about that. Give shout out to Raghu. This is actually his patient that he's been talking about. He cannulated this patient, and as you'll see, he did a great job with the suturing here. So we have 3 sutures all on soft tubing. So this is a very secure cannula that I feel very good about. You could probably yank on this really hard and it probably wouldn't remove at all. So great job, Raghu. The other thing that you want to do beyond just securement is monitor these. One of the things that we've found over time is that when these things come out, it's not usually an acute event that causes them to come out. It's a slow migration by having a patient on for 4, 6, 8 weeks. And so what we recommend is doing daily chest x-rays to look at your cannula position. And when I say do it with the daily chest x-rays, my recommendation is to compare today's with yesterday, and not only that, but compare today's with day of insertion. Because if you're having a small ½ centimeter come out, migrate out on a daily basis, that adds up to a big amount over time that you can miss if you're looking just comparing today to yesterday. And then what we additionally do is we do measurements at the skin level, as Raghu mentioned earlier. So we measure from the insertion site to that tie strap there. We picked those sites because they're easy to pick out. And the other big reason is that's how these cannulas are advertised. So we get the total length is written on all of the packaging for these, and that length is from the tip to the end of the connector, which is where that tie strap is. So if you know how much is on the outside, you can estimate how much is on the inside side, which gives you a measure of safety because you can say, I know that this cannula has like 13 additional centimeters inside the patient, which gives you some level of comfort that it's not about to come out. Additionally, what we also know that we needed to do is make it easier for our team when they're doing these measurements to spot slow migrations. And so what we did is we used our EMR when the patient first goes on, we utilize this, the initial measurement kind of right above the highlighted area there. That's where that only gets typed in at the time of cannulation, or if we manipulate the cannula at all. Right above that is where they do their every 4-hour measurements. Those rows get compared to each other, and then every time they enter this information, they get an estimated migration. If that number is ever above 2 centimeters, they're required to let somebody like Dr. Ragu know, and then we continue to monitor, and sometimes we may even intervene and push the cannula forward if it's creating a dangerous situation. Any questions on cannula securement? Okay, moving on. Fluid management. Don't want to get too deep into this because it's kind of outside my scope of practice. I don't know how to diurese a patient or like know how to order CRRT or anything. But fluid management is vitally important on trying to get patients off of ECMO. Most of our patients are going to go, like for ARDS VV patients, are going to go on in a fluid up state because typically you've tried to they've had some type of infectious process that you've had to fluid resuscitate them through. So you're going to want to get that off through either diuresis or CRRT. And then, like I said, I don't want to go through the pharmacokinetics or anything, but walk you through how, the options of how to do it. Obviously, you can do this through an independent dialysis line, which makes it a little bit easier to make adjustments because you don't have to factor in ECMO pressures, flows, things of that sort. And the bottom one there is pretty important as well, as you can actually decannulate the patients and not have to have an additional strategy. Many times we've gone to get ready to wean, decannulate, and then we had to put it on pause because we forgot to factor in that we were doing CRRT through the ECMO circuit and had to find an alternative source for CRRT. And then there on the side is all of the risk factors involved with using a separate line. The two that are most important in my mind and when it comes to ECMO are obviously bleeding and anticoagulation needs. If you are actually anticoagulating a patient on ECMO, poking them for an additional line is a risky procedure. In the era of not anticoagulating all these patients, a little bit safer though. Doing it through the ECMO circuits, benefits are obviously listed there. We have minimizes additional catheters, improved ultrafiltration, less platelet consumption. I don't know if that's actually true or not. We tend to see platelet consumption, pretty significant platelet consumption either way. But the limitations are pressure changes. So every time, if you're doing CRRT through the ECMO circuit high pressures for any reason, that's going to interrupt your CRRT flow. And sometimes you can get a kind of hit and miss continuation of CRRT. And then obviously you can also send air through the CRRT circuit on into the ECMO circuit. You can mitigate this risk by doing it the way we describe, which is to put it in front of the oxygenator. So if you're using one of those short path polymethylpentene oxygenators, that will usually catch any air that gets in through the CRRT circuit, which is what we have demonstrated here. So this is how we do it on a component-based system. We have a connector between the pump and the oxygenator. We use one to access that sends blood to the CRRT. CRRT machine treats the blood, and then we re-infuse that blood a little bit further down the line, avoiding any recirculation of the CRRT within the circuit, and then ECMO continues on as it always did. What you see off to the left there is ECMO with circuit pressures less than 300. With the CRRT machines that we use at the University of Michigan, we have found that a positive pressure of greater than 300 is not going to work very well with CRRT. The roller pump within the CRRT machine isn't powerful enough to overcome that type of positive pressure. When we get into situations like that, we can do this type of procedure. Although I would, in this particular case, I would advocate for just putting a different line in. But you can do this procedure as well, which is instead of you're going to access that the kind of the same connector on the post pump to pre-oxy side, but then you're going to deliver it back to a negative pressure side for a connector that you place in the pre-pump side. And what this does is this is the negative pressure, so it will have there will be no resistance to the CRRT machine to infuse this way. This creates the tight sphincter that we've talked about for an ECMO specialist, because anytime that you are working with negative pressure and then accessing it, there is a high risk of air entrainment. I would usually caution to avoid this and would recommend going to a line in this particular situation. And then obviously, this is something that we always deal with as an ECMO specialist, when it comes to diuresis, is too much of a good thing. And so this is always a balancing situation that you're going to have to take into account is I want to get fluid off because that's what's going to help me recruit that alveoli well and get the lungs dried out and hopefully get them to a place where they are not on ECMO anymore. The problem with that is that the more fluid you take off, the less ECMO support you can provide. So you're going to have to occasionally, this is where we get into what's called line chugging or chatter, and that I described that earlier is essentially the flow cuts out because the vessel kind of collapses on it, and then you get intermittent stopping and starting of flows. The solutions that we have for that are kind of listed here. I don't like the first one, which is what my team usually wants to reach for first. And I would tell you, let's have a conversation about it first, because I don't usually want to give fluid back. When I give fluid back, that delays the ability to get off of ECMO. So what I want to do is actually, can I decrease flow? Is this patient have enough support where I can actually go down on flow, reduce the chugging, and they'll still be well supported? If that's a viable option, I would tell you to take that first. Is there anything that we can do to decrease consumption? Are they anxious? Are they doing anything like that? If we can give them some anti-anxiety medications to try to decrease that, that's an option as well that I would want to consider before fluid. And then just very bluntly, can we tolerate lower saturations? If I'm satting 92 and now I go down on the flow and I'm satting 85, I'm probably living with that rather than giving fluid. If you've done all of those things and you still can't get the support that you need and your patient's decompensating, that's when you would want to give the fluid back, in my mind anyway. I'm kind of going to skip through recirculation for the most part because it's already been covered pretty well. The only thing that I would say I want to add here is as far as patient positioning. What we do a lot of times is if you see a patient that's on a dual lumen specifically, a lot of times you'll come in and you'll kind of see their necks like this. What we're trying to do is kind of separate the cannulas a little bit, and that'll give you a little bit of breathing room to get a little bit less recirculation. And then obviously change flow. Just kind of really quickly run down these. Obviously, two-site has the highest recirculation at about 30% on average. Bicable dual lumen, a little bit less at 10%. Then obviously the VPA at almost none, just whatever regurgitates across the valve. Weaning, trialing, and decannulating. When it comes to weaning, I get asked this question a lot, is what is your protocol for weaning? And what I usually tell people is we don't have one. And what I mean by that is don't overthink this. If you're treating the patient appropriately, they're going to, in my mind, they just kind of wean themselves. And so what I mean by that is what we have here on the left-hand side, Raghu and Dr. Blank, they always give us at the bedside a bunch of parameters that we want to meet. Usually within that parameter is either a pH goal or a CO2 goal. And so our team will titrate the sweep based on whatever that goal is. And what we usually see is as we've dried them out, as we've gotten them ambulated, while we've recruited the lungs and all of that, what we'll see is when they're starting to improve, they'll get alkalotic. And what we'll do is we'll titrate the sweep down and just kind of keep responding as those lungs start to contribute a little bit. We'll come back on the ECMO circuit and just kind of keep doing that until you get to a point where you are you think you're at a point where you could potentially start considering coming off ECMO. Generally, we're going to start considering that somewhere in the 1 to 3 liters per minute of sweep range. And once we're in that range, you may come off of lung protective strategies to something a little bit more aggressive and start that trial process. And then once we're at 1 liter of sweep before, we'll do something called a Cille test, which is actually Cilley, not the silly word. And that's based off of a fellow that we had. What we do with that, we push the 100% FiO2 button on the ventilator, the only button I'm allowed to touch. And then we see if the saturations come up. If the saturation come up, we know that there's gas exchange across the alveoli, and we're ready to start trialing off of ECMO. So this is what trialing off of VV ECMO looks like. It's kind of a 5-step procedure. The first part is you just remove the sweep. By removing the sweep, we're essentially removing all of the support. We're still going to leave the cannulas in place. We're still going to leave RPMs going. We're still going to leave flow going. That flow isn't going to do anything, though, because we're not treating it. So you're going to pull 4 liters of deoxygenated blood, or venous blood out of the patient, and we're going to reinfuse 4 liters of deoxygenated blood back to the patient. We're going to allow the native physiology to circulate it, and then we're going to just kind of monitor the patient. We draw a gas at the 30-minute mark, see how they're doing. If they look good at the 30-minute mark, we continue on. And my recommendation is hopefully these patients are ambulating and moving. I would continue to do that during trial. One of the big things that sometimes mistakes in my mind that people make is once we're trialing to sedate them, have them resting. I don't recommend doing that. That's going to be a recipe for de-recruiting, and then also they're going to need to move after they're off of ECMO. So we need to know that they can actually tolerate the activity. And then obviously if you're still ventilated, obviously you're going to want to make some vent strategy changes. I usually leave that to Raghu and his team. What I usually see if a patient is indeed ready to come off ECMO, we'll go on to some pretty aggressive lung settings. We'll get that 30-minute gas, and we'll actually have to come down on the ventilator support some. And then time limit and question mark. This question I get a lot. There is no time limit on a VV ECMO trial because you're not stopping flow at all. Everything is continuing to move. You can run these trials as long as you want. The longest VV trial I've ever done was in our neonatal population with an HLH kid that we wanted to make sure that we wouldn't consider putting back on ECMO. So we want to make very sure that he wasn't going to need to go back onto ECMO. Industry standard for this, when I've talked with other centers, is in North America anyways, is about 24 to 48 hours, or a little bit more conservative, and we usually do more like 48 to 72 hours. And then this is an intermediate step that you can do in order to move off of ECMO. If you're still not satisfied after 72 hours, what you can do is you can actually just cut this ECMO circuit away, leave the cannulas there, and then it's a really easy reinitiation of ECMO onto that. So the way you do that is obviously you clamp the ECMO circuit, you cut it away. We will gently flush each cannula line with 2-to-1 or 1-to-1 heparinized saline, looking for clots the entire time. If we don't see any, we'll flush until clear like we have here. We'll then put some perfusion adapters on and then hook up a heparinized saline, usually 1-to-1 or 2-to-1 at about 10 mLs per minute through each of those cannulas, and then we can keep those in for an additional 48 hours from there. Any questions?
Somebody was asking me how do we decannulate.
After you decannulate, you will apply pressure over the site, right?
Yeah, so how do you decannulate? So some people will leave a little bursting around at the time they are cannulating. Some people will put the bursting. So we typically will put, how many of you are surgeons here? Not many, right? Have you ever done a STAM gastrostomy? So we put these 2 burstings around in the stomach. So similarly, we put 2 burstings and then we take the cannula out quickly, just tie the burst.
The skin.
In the skin, that's all. We don't have to operate, we plug it in your approach. And then you put some pressure, half an hour, that's it.
So how long this trial work when you are trying to remove the ECMO? 48 to 72 hours?
That's
So it all depends on how good the patient is doing. Somebody is on spontaneous mode, 40% FiO2. He's looking good, he's awake, there is good aeration, good tidal volume. We'll say, hey, you know what, this guy is ready. I don't think I need to wait too long. And what we will do is we cut off the sweep 24 hours. Next morning it looks good, we take out everything. Cannula, ECMO out, everything out. On the other hand, if somebody is borderline, then we have many strategies. One strategy is to trial off for 48 hours, leave the cannula and the circuit at a high flow. That way we are not getting any clots, but no sweep. So when you are off sweep, there is no ECMO, right? So, and then we observe them for 48 hours with the cannula. And then if you want to be safer, you take off the circuit and leave the cannula for additional 24, 48 hours. So you have the ability to follow them literally for 96 hours, even longer.
So take off the circuit means you cut down the circuit and
Take off the circuit, just leave the cannula, cap the cannula. So in case he fails in another 40, you can leave it for 48 hours.
you can reapply the same circuit and you can change the circuit.
No, they have to change it.
Yeah.
Same like they're like dialysis, if you want to call it. Yeah. So there are many strategies. Some people, they look so good, you're confident that overnight you're going to take off the sweep and everything at one stretch, and sometimes we go slow.
So first step you would do that you would cut off the sweep speed.
It's not like we will do a silly test first to see the native lung. we look at the tidal volume. We are trying to now to figure out how much is the native oxygenation from the native lung. If aeration is good, tidal volume is good, plateau is good, and his response to FiO2, we'll do a blood gas on a 100% FiO2, the silly test or whatever, and if the PO2 jump from same ECMO settings from 40 to 300, from 40% to 100%, tells you that the lungs are really looking good.
Once the lungs are good,
Lungs are good, then it is up to you to figure out how fast or how slow you want.
but the first step is to cut off the sweep speed.
Yeah. Yeah, cut down the sweep and then cap it off. When you say capping off, we are trialing off ECMO.
Yeah.
When the sweep is zero, it's just circulating, but there is no oxygenation happening.
Sir, is it the same process for VA?
Pretty much the same. There they also look at cardiac echo, hemodynamics, whatever the reason the VA ECMO was put.